Okay, test. Alright, everybody. It's a beautiful day outside. Hope y'all are ready to go to work. So if I could get this, there we go. I got my headband on. I got my water bottle. Green headband. Green and white water bottle. I'm at the gym. I'm ready to work. So let's get this started. Okay, so this is where we left off. Super hang on. Chemo Part 2. If you don't know, well, now you know. Well, you'll hopefully start learning. So we first have, man, I gotta get my color right. I gotta get my color right. CSF, colony stimulating factors. I talked about this a little bit yesterday. Kind of touched on it, teaser, but these chemotherapy cytotoxic agents target the fast-growing cells. So what does that mean? Well, that means you lose your hair is one thing it can mean. But for this part of the lecture, we're specifically concerned about the white blood cells, platelets, and red blood cells. So you can have a heavy loss after each cycle. So what does that mean? Implications: low white blood cells, increased risk of infections. So this is where you'll hear, or the board style question will talk about an immunocompromised patient, or you're supposed to know that if a person's on chemotherapy, you kind of assume that they're immunocompromised. Low platelets, so potential increased risk for bleeding. And then low red blood cells, so increased chances of anemia, fatigue, etc. So with all three of these, and the reason I'm covering these is on the board questions, when a person has chemotherapy or is on chemotherapy, you'll have to kind of make these conclusions, or kind of, these are the stereotypes you'll be thinking about. If a person is on chemotherapy, they are immunocompromised, they may have an increased risk for bleeding, they may be anemic, tired, etc. Because of the immunocompromised status, you have to be thinking about diseases that you're not normally thinking about for healthy individual, healthy patients. So for example, TB, CMV, PCP are a few. They're not all, but those are a few kind of frequent flyers. The other thing too is that a lot of chemo regimens require the patient to have a permanent central line in place. So that's a big way, or an easy way, to get infections or infected, and then they're in and out of hospital facilities or healthcare facilities, so increased risk of MRSA and Pseudomonas. So it'll be in hospital-acquired MRSA, potentially. So what a strategy you can employ, or that people employ for these patients, is to give to either prevent or to treat neutropenia. They'll give the granulocyte colony stimulating factors, GCSF. So for example, if a patient's ANC, absolute neutrophil count, dips too low, then they'll give the granulocyte colony stimulating factor to help correct it. And then they will probably prescribe it prophylactically for the next cycle. So how do you pick which one? Yippee hooray! Protocols, yeah! So typically you just look to the institution where you work, or where you're rotating as a student, etc. The good news is there's protocols, and there's usually based on guidelines, so you don't have to stress too much about trying to figure out what specific, which one to pick. Here are some examples of ones that you may see, and usually, so my experience at least, people refer to them as their brand names, so that's why I included their brand names. So Neupogen, Zerixio, Granix, Neulasta Onpro, and Leukine is usually what people refer to them as. And to me, those are easier to remember, but you could see either, potentially. Don't worry about memorizing this for my testing purposes. Excuse me. I just have that there so you can kind of see some potential dosing regimens and get an idea of how it may be prescribed. So, and the leukine here is a little bit different in that it stimulates both granulocytes and macrophages. So it's particularly used for, one sec, there's a freaking mosquito. Got it. Alright, so I don't have to worry about Zika today. Alright, sorry, I have mosquitoes in my office, and they drive me crazy. Mr. V was laughing at me yesterday in the hallway because I was chasing an invisible monster. No, he didn't know that I was chasing a mosquito, but I was just slapping at the air like a madman. He's like, "Are you okay?" Okay, so anyways, that was funny. Yeah, mosquitoes. So what was I saying? Yeah, so leukine specifically will be used for stem cell bone marrow transplants. So you may or may not see that depending on where you end up practicing. So here's some pearls for you guys. So don't start any of these except for the Neulasta Onpro. So Neulasta Onpro is a different delivery system. But anyway, so don't start any of these until 24 to 72 hours after chemotherapy. The rationale is that if you give them before or during the chemotherapy, that all the neutrophils that they're stimulating are going to be killed by the chemo. So the rationale isn't there, and you're not really helping the problem. You're just giving, kind of giving excessive medication, etc. Like I said, with the exception of the Neulasta Onpro, so this is this new drug delivery system. It's an on-body injector. Excuse me, that a nurse will probably stick on the patient in the infusion room the same day of chemotherapy, and then it has an auto-inject mechanism for 27 hours later. I think that's a typo. One sec. I think it's supposed to be 72. One sec. Okay, so this is interesting. I went to UpToDate. My best friend typed in the name, go to administration. And I'm just going through this because I figured, hey, this could be educational for you guys. But so it is known as an on-body injector, which is right here. On-body injector. So it is 27 hours. It wasn't a typo. Because of my dyslexia, I flip numbers all the time. But so you put the on-body injector system approximately 27 hours after application. So this was correct. Not a typo, but so anyways, 27 hours. So that's interesting. So that's the only one that you would administer that day of chemo. So that's interesting. And then the advantage of this Onpro, this auto-injector, is that it saves the patient from having to return to the infusion center. And then just note, if you ever see a patient on, they can't shower while wearing the Onpro. The device doesn't like water. So some more pearls we have here. One of the major side effects, or kind of the most common complaint here, is bone pain, unfortunately. So that's something to remember for adverse effects. They don't really know exactly why it causes bone pain, but they think that it is because of a histamine release, that it's involved in an inflammatory process. So because of that, you typically see an antihistamine prescribed, specifically loratadine, which you guys will remember from before, is a second-generation antihistamine, and this is generic for Claritin, so over-the-counter medication. So you'll see this prescribed with these GCSFs to help manage this pain. So, and I made this presentation during spring break, and I cannot remember why I included this photo, other than it's making me laugh right now. So cuddle up to your dream date with your own portrait pillow. So I gotta get one of those made, I guess. I don't know. So just ignore that. I don't know why, and I don't know why I'm putting arrows on it too. Let's just X that. Yeah. So take-home point is antihistamines will help with the most common adverse effect of bone pain. This is not the take-home point. Some more pearls to watch out for. So another adverse effect that you have to be concerned with is splenic rupture. Not as common, but it's one of those rare but serious ones, because a ruptured spleen can be fatal. And basically these medications clog up your spleen in a nutshell, and so that can cause a fatal rupture. Also rare but serious, but there's a small risk of an anaphylactic reaction. And then with anything injected in the pharmacy world, you always want to think about, or remember that injection site reactions are things that can just occur. It's kind of like every medication has a contraindication of hypersensitivity. It's like every injection has this potential for so-called injection site reactions. Erythropoietin stimulating agents. So these, I'm changing gears a little bit. So this is if there's a drop in red blood cells. These help stimulate red blood cell production, so increase in RBCs. However, there is a very strict usage criteria. Very, very, very strict. So again, as far as your prescribing habits, etc., unless you're with a specialist, you probably won't be doing this. And even specialists are restricted in how they do it. So very strict usage requirement in cancer patients with these agents, these ESAs, erythropoietin stimulating agents. So there's this big specific protocol, etc. So it's the ESA ESA prize. So hopefully this hyperlink works for you. If you want to look into it, you can, but don't worry about it for testing purposes, and don't really worry about it for the boards. I'm just putting this here just for completeness sake, and that you just know that, you know, if you are thinking about giving an ESA for a cancer patient, they're very strict about when to use it, when not to use it, etc. So, and then just if that ever happens out in practice, refer to the ESA a prize, not a praise. So when it is used, the majority of it's used with chronic kidney disease. So this is not. So I'm sorry. Out in practice, you probably won't see it for cancer patients, but you probably will see it with chronic kidney disease. And this is because your kidneys supply your body with erythropoietin, and their ability declines with time, so that you need the supplementation. So less erythropoietin means less red blood cells, which means potential for anemia, poor oxygenation, fatigue, etc. So it is very common that you will see these used in kidney failure. So much less common in cancer. Like I said, very strict restrictions. And part of that reason is because these ESAs are associated with an increased risk of death and tumor progression in cancer patients. So they are only indicated if they have a chemotherapy-induced anemia, and again, refer back to this ESA prize, very strictly controlled. So the majority of time in practice, you guys will see these. I would make bets that you'd see it being used in chronic kidney disease and not in cancer patients, unless you're with a specialist. I don't know. I make a lot of predictions that aren't true, that don't come true. Okay, I'm sorry. I'm sorry, future yourself. So again, just for completeness sake, here are a couple ESA agents. So we have Procrit, aka Epigen. So Epigen Alpha has two brand names. This is dosed in units. It's usually given several times a week, just FYI. Arnest, the darbepoetin, Aranesp, micrograms, and it's usually given once every 1 to 2 weeks. Excuse me. So therapeutically, these are both considered equally efficacious. Specifically is which one you guys are going to pick and which ones you guys are going to prescribing. Probably again for chronic kidney disease. Will be dependent on the cost, convenience, and then the formulary. Again, where you work will drive your decision and which ones you guys will be prescribing. So here's some pearls that'll hopefully help you guys out in the future. So when you are prescribing these and administering these, just remember that you won't typically see an increase in the hemoglobin hematocrit for about 2 to 6 weeks. They are some adverse effects that you have to be concerned about when you are prescribing and using them. So most notably, you can be concerned about hypertension, and then especially if a patient already has issues with hypertension, stroke, and then VTE. Excuse me, man. I was trying to. I've been really good about pausing my coughs. So I'm really sorry about that. And it just seems like I'm allergic to recording lectures now. Like I just get sick if I have to record. So again, apologies all around. you'll find the general goal for ESA is to decrease blood transfusion. That's the main goal of giving these. So you typically don't try to treat to get to a normal hemoglobin. You typically will stop around 10 to 11. So for testing purposes, I mean, pay attention to this for me, adverse effects, but some of the stuff I'm just going through is I'm just trying to give you guys, you're closer to rotations, you're closer to start seeing the real live patients, and so I'm trying to give you guys some pearls that'll help with that. But one of the reasons that you don't go all the way to normal is that you can help reduce the chances of side effects, and then they're expensive too, so that's also another good reason. Platelet stimulating agents. So these are very, very rarely used in chemotherapy. And just again, here for completeness sake, you probably won't see them. Even with this, if you worked with an oncologist, probably still wouldn't see them, prescribe them. Never going to be your first line treatment choices. And so typically with the cancer patients, they just do the good old fashioned platelet transfusion instead of another drug that can stimulate cell growth. So if it's used, not first line, and so you typically just will go with platelet transfusions for cancer patients. But then again, just for completeness sake, here they are: Numega, Promacta, and Nplate. So again, these are usually referred to as brand names, so I put the brand name. And excuse me, just read through these. Don't stress too much about memorizing it, etc. for testing. But just note, Numega is the only platelet stimulating agent that has been FDA approved for chemotherapy-induced thrombocytopenia. So that's just a fun fact for y'all. Here's some pearls for these. They all stimulate platelets. Thus, there's an inherent risk for inherently increased risk for clotting with all of them. So you definitely need to monitor your patient if they are for signs of clotting. The other interesting kind of thing, fun fact I guess, is Numega is actually derived from E. coli. So there is a risk of anaphylactic infusion reactions, typically on the first cycle. The other thing too is that these just may not work for your patient. So and so if there's no effect in platelet count after 4 weeks, then just go ahead and DC it, quit using it. So, and like I said, it's typically not even first line, but just for your knowledge. Super hang on. Okay, so what do we got next? Hypercalcemia of Malignancy. So I don't think this has been covered in other courses. You guys have noticed I've asked like 20 questions about how loops lose calcium. So this is why, because you see board questions about hypercalcemia related to malignancy. So this is my pearls lecture, so to speak. This will be the highlight reel, and hopefully will help you make sure you crush the boards. So a little history or a little story, whatever pathophys. So certain solid tumors, specifically in the breast and lungs, and then some blood tumors, so for example multiple myeloma, will increase the risk of hypercalcemia, especially due to the cancer cells that themselves will pump out calcium. So actually sometimes the cancer cells are pumping out calcium. Mostly due to the fact that breast, lung, and myeloma cells like to metastasize to the bone, where they cause resorption. So another reason, increase calcium. The other thing too with multiple myeloma is they create a bunch of immature plasma cells that will then clog up the kidneys, and that can further cause renal failure and then calcium accumulation. So another reason. So take home point, increased calcium with cancer, and specifically breast, lung, and multiple myeloma. Hypercalcemia is something that must be monitored in cancer patients. So I don't know why that reminded me. Stevie Wonder, Michael Jackson fans get it. So you guys can. I think if you click on that, it takes you to the video clip. So hopefully I did that properly. So, but don't worry about it. You don't have to check it out. There's nothing on the test or anything. So typically you don't treat asymptomatic hypercalcemia. So symptoms you're going to want to look for are thirst, confusion, weakness, nausea, vomiting, diarrhea, etc. So you want those symptoms, then you want a symptomatic patient with hypercalcemia. You probably remember this, hopefully, from my other lectures, but you're going to want to avoid thiazide diuretics and calcium supplements or antacids. So the antacids have calcium. And then you're also going to want to make sure you monitor renal function. So symptomatic patients, you're going to usually first hydrate with saline. So this will help cause a relative dilution of the serum calcium level and help reduce the symptoms. But you definitely need to be mindful of volume overload, so you don't want to overload the patient. And if the patient's kidneys can handle it, they'll sometimes give furosemide. So that's where they say the loops lose. This is where they say the loops lose calcium. And just make sure as long as you have the healthy kidneys. And this is interesting in a rare instance where you actually give a diuretic and hydration. So you'll give the saline plus the furosemide. As an added bonus, the furosemide, or you could use any loop diuretic, just furosemide is the most popular, will also help to remove some of the serum calcium. So loops lose calcium. Please note, loop diuretics can contribute to acute renal failure. So use them in caution if your patient already has compromised kidney function. So that's why it's up here. If your kidneys can handle it, because unfortunately sometimes the loops, or theoretically the loops, could make that worse. So you don't want to give the loop diuretics to someone with weak kidneys. Second, usually they go to calcitonin, and there's actually more evidence now. There's kind of been more research done where calcitonin may be first line over the loop diuretics and furosemide. However, out in practice and historically, the loop diuretics were popular and they're cheaper, and just people are more familiar with them. But so calcitonin, you may see that being used more and be preferred as more first line over the loop diuretics. But anyways, it's not incredibly effective at lowering calcium, but it works quickly, and that helps when symptoms are present. So this is a fun fact for you, any fish lovers out there. But so formulations of calcitonin are derived from salmon, so you have to watch out for salmon or fish allergies. I always want to say salmon, but it's salmon, right? That's how people say it. Salmon. So it is a contraindication to give this if a person has a documented hypersensitivity reaction to fish, and then more specifically to salmon. Then you typically will go to a bisphosphonate. So, and you guys will hopefully remember that you go IV, not PO. Or the Denosumab. So Denosumab, you guys hopefully remember, it's a RANKL inhibitor. So I have a little more information. Next slide. These help remove a lot more calcium from the serum compared to calcitonin. However, they take longer. And they aren't as safe. So 2 reasons why they're not maybe first line. And they won't help with that immediate kind of symptom reduction, which is one of the goals. Because remember, you only treat the symptomatic patients with hypercalcemia. Remember that bisphosphonates are contraindicated in renal failure. The most common IV form is this IVZA is what you see. Zoldronic acid IV formulation. You may also say the pamidronate. That one's also popular IV. They both must be renally adjusted or avoided altogether if the creatinine clearance drops below 30. So that's where that contraindication comes into play. If the patient does have renal issues, this RANKL inhibitor, Denosumab, is going to be a better choice because you don't have to worry about the kidneys. So there's no recommendation for renal adjustments with this medication. However, you do have to watch out with hypocalcemia because this can profoundly lower calcium. So that's something to worry about. And then you also have to worry about infusion reactions and hypersensitivity reactions with Denosumab, because it's a monoclonal antibody, right? MAB. So that's something to take into consideration too if you do decide to go with the Denosumab. So here we have the zoldronic acid, which is the bisphosphonate we talked about earlier, the IV. Brand name is Reclast. Also brand name Zometa. Same medication, both ZA, zoldronic acid, IV. The Reclast had FDA approval for osteoporosis, versus the Zometa has FDA approval for oncology indications, so to speak. So I just put these dosage here, but don't worry too much about it. But excuse me. Just read through that, kind of FYI. Just note that you have to worry about the kidneys with these bisphosphonates. And then Denosumab, same thing like zoldronic acid. So 2 different brand names, FDA approval. Prolia has the osteoporosis FDA approval, which is Xgeva. I hate that name. Has the oncology indications, and you don't have to worry about the renal adjustments. So here's some more on the Denosumab. Prolia. So because I don't think I have given you this information before, so that's why I put a little bit more information on this just to make sure. It's a newer agent, newer medication. The category for it is a bone modifying agent, and it's a monoclonal antibody because it ends in MAB, right? It can be used for hypercalcemia of malignancy, osteoporosis, bone loss, and then in tumors. So for cancer, these are the 2 uses that it can be used for. So read through those. Super, hang on. Okay, what's our next section? So now we're going to talk about neutropenic fever. We talked already how chemotherapy can destroy white blood cells, and some of the implications with that as far as infections, but it can also it also has some other implications, and specifically neutropenic fever, because destroying white blood cells, especially the neutrophils. And so the neutrophils, you remember from pathophys, are a critical component of your immune system. So normally your body gets sick, it lets you know. You feel achy, malaise, and you have a fever. However, when you barely have any neutrophils, your body doesn't do that. It doesn't just go to achiness, or it just jumps straight to the fever. Because that's the only way the body is left to tell you that you're sick. So you get a really, really bad fever. It's one of only a handful of emergencies related to chemotherapy, so definitely put a start by that. So neutropenic fever is a very serious thing, and it's one of the most important things to warn your patient about when they go home after getting chemotherapy. So this is one of those where you will say, if you get a fever, go straight to the emergency room. So again, depending on where you work, you may never have to advise this, but definitely if you're in working with patients who are regularly receiving chemotherapy, and the facilities are good about this. I mean, everyone knows about neutropenic fever and how it can be an emergency. So there usually will be patient handouts, patient education, signs. They're stressing this and they're repeating to and then family members and then caregivers too will need to be notified of this. So time is critical with neutropenic fever. So basically, you don't have an immune system, right? Or it's lowered, you're immunocompromised, as we talked about that earlier. So a normal, quote-unquote, UTI or pneumonia, cellulitis, quickly can become sepsis. And sepsis can quickly become septic shock, and septic shock can quickly become death. So that's just why it's so important and why it's considered an emergency. It's also sometimes called febrile neutropenia, but neutropenic fever. These are the IDSA, are the guidelines you can go to, and hopefully you can click on that hyperlink if you want to read through those. Usually they have protocols and setup, etc. But so this is the cutoffs, or what the definitions for the fever. So and you just read through these. And this is the definition for neutropenia. So definition for fever, definition for neutropenia, and then definition for profound neutropenia. So they have the definitions, or the cutoffs there for the ANCs. Excuse me. And it's just interesting too that they do a manual reading of the blood smear is required to confirm this count because it's so low. So, and again, just in stereotyping, majority of people with neutropenic fever will get IV antibiotics. So just think IV antibiotics. If you see this person in your emergency room setting, etc., think IV antibiotics. So, and the strategy goes that you first get 2 sets, and these are based on guidelines, by the way. This isn't just me making stuff up and kind of what I think is good, but this is based off those IDSA guidelines. You're going to first get 2 sets of peripheral blood cultures from separate sites. This way the offending agent organism can be identified, and then the antibiotics need to be streamlined. Next, you want to give broad spectrum antibiotics, and you want to cover for Pseudomonas. So just real quick, okay, so I pulled this up. This is that antibiotic utilization highlight chart that I gave you guys. So Pseudomonas coverage here. So broad spectrum and then Pseudomonas coverage. So that's why I like, part of the reason I like this. So carbapenems except ertapenem. But so here we have the ones that cover that. But so this is could be a good chart and help you guys with that. But so you definitely want to be thinking about Pseudomonas, and you want to be culturing. Let me get my stupid. So a lot of times you'll see them go with cefepime. Pip/Tazo is another choice. You typically don't need to worry about anaerobic coverage. So broad spectrum, you want to hit Pseudomonas, cefepime, or Pip/Tazo, and it, depending on your facility, they'll have, maybe one will be on the formulary, one's preferred over the other, but either one could be appropriate. And then if the person has an access point, such as a central line, so you need to be thinking about MRSA, so you typically will add vancomycin on top of that. So vancomycin plus cefepime, vancomycin plus Pip/Tazo to make sure you're covering for MRSA. You also want to give supportive care for blood pressure, start a fluid bolus, usually normal saline, and then you will add pressors in a stepwise manner until goal blood pressure is achieved. Norepinephrine is usually the pressor of choice in septic shock. And this I would definitely recommend, and probably before your ER rotation or inpatient or whatever. I don't know what all you've gotten on sepsis, but check this out. Surviving Sepsis campaign is for the guidelines. It's got some really good stuff in there and explains this more in detail. So not for testing purposes, but for your knowledge and for boards, etc. And then when you're out in practice in the ER or wherever. So, and then once you have the blood cultures back, then you streamline therapy. So you start broad, and then you zoom in on what specific bugs you need to hit. And then if the fever persists for no apparent reason, you may need to think about doing antifungal treatment. And then with the antibiotics, you want to make sure you can continue them until the ANC is greater than 500. Sometimes you will want to do a prophylactic treatment. So for high-risk patients, so for example, if a person has leukemia or lymphoma, you may go ahead and do prophylactic treatment. Most frequently, it's going to be fluoroquinolone, so ciprofloxacin or levofloxacin for bacteria. And then sometimes they'll add acyclovir or valacyclovir for HSV prophylactics. And then if you're interested in covering for antifungal, they'll typically go with fluconazole. So that's an idea of what you might see. And then again, you do the prophylactic coverage until ANC is greater than 500. So, and these can vary a little bit too, again, depending on where you're working, if they have protocols or if they have things. So Cipro is preferred over whatever, and then also dependent too on local resistance and stuff. So if everyone's resistant to levofloxacin, go with Cipro, etc. You super hanged on, you did it. So click here and you can listen to the awesome soundtrack of Super Hang On. So that is it for chemo for me. Yep, that's it for chemo. For me, like I said, it's an overview. It's a lot of pearls. It's a streamlined, highlighted, high yield presentation. So some good stuff in here, and I think will help you for your boards and then for your patients in the future. Going to thank you too. Hopefully, another prediction. So if you don't know